Good evening, everyone. Can you all see my screen and hear me?
Yes, we can see. Yeah.
Good evening. I'm Dr. Maithri. I'll be presenting a case on salvaging vision in a case of craniometaphyseal dysplasia. A 5-year-old girl presented to us of poor socioeconomic status in September 2021. She was referred to us for a routine ocular examination, and they were suspecting a skull dysplasia for her because of changes in her facial bones and deformity that they could see. For us, on examination, everything seemed to be normal, including the vision and everything, except for the adnexa, which showed puffiness around the eyelids with a prominent intralateral margin. Even the disc and the macula were normal on fundus examination. So we just routinely told her to come for a follow-up every 6 months. But 6 months later, when we saw her in March, she was referred again for to evaluate her for loss of vision. And there was decrease in vision since just 1 month, but they were not really sure of the onset. The genetic test for the skull dysplasia was still underway, and they were still awaiting the results. At this point, when we saw her, her vision had deteriorated bilaterally to 6/48, but on fundus, we even found a temporal pallor of the disc. So now we were wondering why this could be, and if it's because of the skull dysplasia itself. We did attempt an OCT, RNFL, and GCC, but it was not possible since she's just 5 years old, and she was not really able to fix well. So we were thinking of compression of the optic nerve at the optic canal, which is actually seen in cases of dysplasia. So we did refer her urgently to neurological cause of optic nerve compression and loss of vision, and to consider deroofing or decompression of the optic canal if compression could be confirmed on radiology. And we, of course, asked her to review post-intervention. When she came to us again in April, 1 month later, we saw that actually no intervention was done, and the vision had further reduced to 6/75. Her pupils at this point were sluggish. She had an eccentric viewing on upgaze, as you can see in this picture here. And the MRI brain showed a trigonocephaly with prominence of bilateral ventricles with signs of raised ICP. And the interesting thing was her ALP was very high, 887, which is kind of the diagnostic of craniometaphyseal dysplasia. Because of the signs of raised ICP that we could see on the MRI, we went ahead and did a USG B scan and found that there was a prominence around the optic nerve, the perioptic sheath. So there is SAF present around here, around both the nerves. So at this point, we knew that intervention has to be done in some form or the other. And we diagnosed her to have craniometaphyseal dysplasia with possible bilateral optic canal compression with raised ICP. And again, we referred her urgently to start treatment for raised ICP. And when we saw her back in May, she was treated, but only medically with IV mannitol, and then she was on oral acetazolamide. Canal decompression was not done because they were afraid of the risk of bilateral blindness post-canal decompression, which has been reported in a few cases. But at this point, her vision was counting fingers in both the eyes. The repeat contrast-enhanced CT showed an abnormally thickened skull, narrow optic canal bilaterally with significant compression. And there was persistent ACF on B scan. So just to review, from September to May, as in the course of just 8 months, we saw her vision deteriorating quite significantly with signs of raised ICP and like an optic canal compression on the contrast-enhanced CT. So this could be probably because of the progressive hyperostosis that can lead to optic canal compression, raised ICP, optic atrophy, and rapid progressive loss of vision. So definitely at this point, some sort of intervention has to be done. But what do we go ahead with? Do we do canal surgery? Do we do optic nerve sheath fenestration? Was the question for us. After much contemplation with the neurosurgeon and a lot of discussion, we went ahead and decided to do a unilateral, that is the right frontotemporal craniotomy with right optic canal decompression, along with a bilateral optic nerve sheath decompression. So the canal decompression was handled by the neurosurgeons, and intraoperatively, we found a thick bony dysplastic changes of the sphenoid and over the optic canal and base of the skull. The optic canal was deroofed at the level of the anterior clinoid using a high-speed drill by the neurosurgeon, and there was ballooning of the optic nerve. We, of course, went ahead and did the bilateral optic nerve sheath decompression through the medial transconjunctival approach, which we usually follow. Post-operatively, her vision, though, continued to be counting fingers 1 meter. The eccentric viewing persisted. The optic dyspallor, of course, continued to persist, but there was no SAF on B scan. And she's maintained like this for over 5 months post-operatively. She's able to go to school, able to read and write, and visual aids and further rehabilitation is planned, and serial radiological scans are also planned in the coming months. So coming to discussion, craniometaphyseal dysplasia is a rare genetic disorder which is characterized by progressive thickening of the skull. This can cause compression of the cranial nerves and can lead to blindness, deafness, and other cranial nerve palsies. There have been multiple case reports where they have shown that endoscopic ONSD can cause some sort of relief to progressive vision loss and can maintain the vision as it is, while Caroli et al. Suggested that any kind of surgical intervention has to be done only if there is progressive loss of vision. A few cases of total blindness has been reported postoperatively where bilateral optic canal decompression was done, which is probably why the neurosurgeons were apprehensive in the first place. The rapid progression of visual loss could be due to the decreased venous flow and raised ICP, and also due to the compression of the optic canal anatomically, which prompted us to intervene surgically. But to prevent blindness and yet to salvage the child's vision, our approach in this case was to perform a unilateral optic canal decompression with bilateral nerve sheath decompression. Though the child's ambulatory vision and visual function remain stable post-surgery, with which we are currently happy. So to conclude, this kind of unilateral canal compression with bilateral ONSD in a case of CMD has not been reported so far in India. And cases of CMD have to be monitored closely for vision loss, and serial radiological scans have to be done since it's a progressive disorder. It can progress even after surgery. Timely diagnosis and prompt surgical management with the aid of definitely neurologists and neurosurgeons can prevent further deterioration and provide better quality of life. Thank you.
Wonderful presentation. Wonderful. On to you, Dr. Jyoti.
Yeah, so this is a very interesting case and I wanted to discuss because in children, they behave very different. Now, this child, when she came in, when in September, had good vision and she started deteriorating. But if you see, she was getting adjusted to whatever vision it is. So children don't complain. And that's the reason why they can, if they go blind, and it is blindness for life. Now, this condition, craniometaphyseal dysplasia or CMD, is actually a condition where the bones keep becoming harder and it's difficult actually to treat this problem. And for that, we had to constantly talk to the neurologists, the neurosurgeons. We had to make them understand that the child is going blind. Now, incidentally, because she had a temporal pallor, the raised ICP was missed. And we try to get, like what we do is in an adult, an OCT, and fields, which is not possible in a child. They don't do. So only on the basis of the vision, and probably in this case, because of the raised ICP on B-scan, we could actually monitor the child. Now, when we told to the neurosurgeon that this patient is going blind, they said, if we go ahead and do bilateral canal decompression, she is going to go blind. But what we are trying to explain is anyway, she is going blind. We should do something for it. So one option is using the high-speed drill. They say if you do that, the chances of directly, when they're trying to open up the roof, the canal, that is the canal roof, it's possible that it may not directly cause blindness. And therefore, we said at least go one ahead, go with one eye, and at the same time, we'll do the ONSD for both eyes. So constant talking to the neurologists, to the neurosurgeons made us really helped us to go ahead and do this. And luckily, being in Health City, we could do it simultaneously. So they went ahead, did the de-roofing, and at that time, we could see neurologically that the discs, the optic nerves are really ballooned. And then we went ahead and then we didn't go through their approach, but we went through our normal approach and did optic nerve sheath decompression. And luckily for us, now it's been like we saw her in November, she is stable. At least she is able to be ambulatory. And for her, the minute before we went in for surgery, we realized that she was not having a direct eye contact. She used to look in up gaze, and that's the way she could. So she had lost vision to such an extent. All we could do is try to have this. So we literally had to convince the neurologists, the neurosurgeons, like we should go. So one other thing is in these cases is in addition to the canal being compressing the optic nerve, the raised ICP that follows is also one thing. So in a patient who has temporal pallor, the B-scan actually guides us in picking up this disc edema, which otherwise cannot be seen because you have already pallor set it. So that's the way how we could monitor and go ahead and do the surgery. So basically what we know is, yes, these in this condition, eventually all cranial nerves get involved and the patient may go blind and it may be fatal for the child eventually at 20 years. But as long as she is living, at least she should be able to see. That was our bottom line for presenting this case.
Amazing. Wonderful.
Can you just ask one question, Dr. Jyoti?
Yeah.
The cause for the vision drop in this child, was it a compressive optic neuropathy due to narrowing of the optic canals, or is it a raised intracranial pressure that is causing the optic nerve weakness?
Actually, very difficult to say because both could be causing. But the thing is, on table, prior to that, we realized that there was raised ICP and there was also narrowing. So if we presume that it is the narrowing alone, then the other eye would have, because we have done only de-roofing in one eye, we have not done it in the other eye. we would presume that that eye at least would have gone into blindness. So I feel that the basic canal narrowing takes much more longer time compared to the immediate raised ICP causing it. Because
No, but what was the cause for the raised ICP?
I'm sorry.
I mean, what is the cause of the raised intracranial pressure?
So what
The local pressure may increase because of the outflow, because of the canal narrowing. But overall intracranial pressure should be normal, unless there is an increase in the bony thickening at the third or fourth ventricle at the base of the skull. Unless that is also there, which is not usually seen in these kind of dysplasias, the pressure around the nerve would be more because of the drainage outflow problems.
So what they were saying is because of the canal narrowing, you are having a secondary enlargement of the optic nerve sheath right around the optic nerve head, and that is what you need to relieve at the same time. So
I mean, I would have thought that, I mean, one would prefer to at least go back and do the other eye canal decompression, because eventually the cause of this is the canal narrowing and not directly. I mean, we have cases of fibrous dysplasias. So the key is the narrowing of the canal, resulting in one, direct compression, what Dr. Ambika was talking about, and two is CSF and venous outflow compression of the peripapillary, perinerve blood vessels. So that also can cause the thickening and compression. So yes, I mean, I would say follow up the child, because there is a possibility that the other eye where the canal has not been decompressed may eventually suffer damage because of the narrowing, further progressive narrowing of the canal.
Yeah, so
I had a
thing, it will cause a primary optic atrophy as a presentation rather than a papilledema and a secondary optic atrophy. I think we had in RPC, if you recollect, Rohit,
Yes,
osteopetrosis, which was a
osteopetrosis. Yes, sir.
that presented as a primary optic atrophy.
Yes, sir. So in this case, probably the outflow is also being compressed. Overall CSF pressure would not have increased or does not increase in these kind of cases.
Here, I think arachnoid granulations are being compromised. Because of the osteopetrosis or the changes in the skull area, there is the arachnoid granulations outflow is being compromised. That causes, I think, the raised.
Was the CSF raised? Did they do a CSF tap? I mean, overall, because if that is so, then you would require an intervention for the overall increase in CSF pressure also.
They found some amount of ventriculomegaly when they did the MRI scan. But what primarily I feel is the canal compression, which is causing the secondary enlargement of the fluid around it. However, to convince them to do one eye was not so difficult, because the neurosurgeons believe that no, she is going to go blind. I said, like, anyway, she is going blind by the course itself. So kindly do it. So convincing them was more difficult. But yes, we have to do periodic CT scans, because even if we have de-roofed them, eventually because of this bone formation, this again is going to narrow.
Need to be compromised further.
Yeah, I agree with Dr. Pradeep Sharma. I had seen a similar case, but that was, like of osteopetrosis, and that had led even, Arnold-Chiari type 1 malformation and raised ICT.
And if at all there is a space constraint, as we discuss here, when the canal is narrowed, if there is a raised CSF pressure or something, you see, sometimes we see like a meningoencephalocele type of ballooning out of the optic nerve sheaths, where we can mistake them for a raised CSF pressure. And I hope the child had only the skull bones, where any long bones or any other parts of the body have also had these sort of bony abnormalities, Dr. Jyoti?
Right now, no. It was only the skull.
Okay.
So was there a craniosynostosis?
And
Was there a craniosynostosis?
In fact, she had, it started when she presented, she had a round face. And when she subsequently followed up with the pediatrician, they realized her face had become like a square. And that is when they started suspecting maybe this is some sort of a dysplasia. And then they started getting her CTs done, and they started getting the genetic work of her.
So did they try transnasal or sphenoidal, or directly the craniotomy approach was the preferred modality?
We actually operated in the neurosurgery OT. So when they did ahead, they did with a high speed, but they opened it up. In fact, Dr. Maithri was there when they did the surgery. And when they removed that, you could actually see the whole thing balloon. So basically it was this canal compression which is causing the ballooning of the optic nerve. So you could look through the brain and see that the whole optic nerve is ballooned up.
So actually, like, because Dr. Jyoti said that I was there
Thank
during the surgery, I just wanted to say, when they were doing the surgery, I could see that they had to drill the clinoid process and all that. And the neurosurgeon was telling that it took him 3 times the time that he would take for a normal drilling, even with the height speed drill. That was how thick her skull was. It was almost 3 times thicker than normal. And I could actually see him go down into it and the whole brain and all the structures there. So it was quite fascinating to watch.
A wonderful webinar and a wonderful discussion, and truly most enlightening evening. I think it's only adjectives and superlatives for this kind of webinar. Thank you so much, dear expert panel, for all the discussions, and thanks so much, great speakers, great quality of talks of each and every one of you. Really, thank you. Thanks a lot, and thanks, Murli, for everything you do to help me do this Neuro-Ophthal webinar, such a great style and attention to detail. And thanks a lot, ARC, for being with me. And we have Rohit here to represent the others. And I really need to thank them for being constant energy and support for me. I think we need to also thank the AIOS admin with Kripal. We need to thank Sai and Manjula from Numerotech for the mailers. We need to thank Mr. Sunil, who did a decent job, wasn't after us all the time, but he could have been, maybe would have finished some 20 minutes earlier. Thanks a lot, Mr. Sunil, for your massive support. He would shortly be telling us also about how many attendees watched this webinar and enjoyed it as much as we did. And finally, we need to thank NTOD for the constantly being supportive and sponsoring all our webinars. And of course, all our attendees for watching these webinars. And that gives us so much energy to keep trying innovative ways of making it interesting for you all. Thank you very much, one and all of you. Thanks a lot. Thank you.
Thank you, Ramachandra.
And
Thank you.
really appreciate every webinar, every specialty. You just do a great homework, come up with the specialty questions, Dr.
Yeah.
Chitra.
Very
That's
good.
excellent of
Absolutely.
yours.
That's
Thank
wonderful.
you.
That's
Thank you,
amazing.
Thank you.